for our next presentation. And the speaker names today and their roles are in alphabetical order are Jeannette Watts, Nurse Manager with the Nuu-chah-nulth Tribal Council, Kristen Young, Community Partner with the Huu-ay-aht First Nation, Lisa Bourque Bearskin, Associate Professor, BC Indigenous Health Chair in Nursing for TRU, Ruth Charlson, Project Manager, Nursing the Nuu-chah-nulth Way, Samantha Christensen, Community Partner, Kyuquot First Nation, Victoria Lynn Dick, Research Assistant, Catalyst Project, Nuu-chah-nulth Tribal Council, and Daniel Blackstone, Community Partner, Kyuquot First Nation. And the presentation title is Listening and Learning and Research, Nursing the Nuu-chah-nulth Way. Now I'll give you guys the virtual mic. I did my best with pronunciations. My apologies if I pronounce anything incorrectly, and I welcome correction. Thank you.
Thank you for that introduction. I'll call on Lynn. Ruth, I see, is here. Samantha is here. And Daniel, I don't see is here yet. Daniel, are you here? And can you put your face on? Can you put your face on? And can you tell me if you could see my screen properly right now? Sorry, I should have.
Yes, we can see it, Lisa.
My notes too, or just? Can anybody see the notes?
There you go.
There we go.
Okay. I'm just gonna try to minimize my screen so I could email Daniel, but I'm not sure I can. Sorry about this. Lynn, I'll let you start off and maybe I'll try to figure out how I can minimize. Is there a way to minimize my screen? Sorry, anyone? No?
Excuse me, it's nice. Lisa, I could message Daniel for you.
Okay. Yeah, just I think he'll need the new link or the current link. He was on the other Zoom link.
Good morning, and thank you for having us here today. We're grateful to be here. And I would first like to thank the communities who graciously welcomed this research team in to work with them to build these really trusting and open relationships. And also for joining us today to share their voices. I think it's really important to have the community voices come from the community themselves. My name is Ntc Nursing. My English name is Lynn. I'm from the Ntc First Nation, which is one of the nations under the Nuu-chah-nulth Tribal Council. I have family in probably half the other nations within the Tribal Council. Today, I'm on the unceded traditional lands of the Huu-ay-aht and Ntc First Nations. These are a list of some of our research team members and community partners. The ones who are speaking to their part will introduce themselves a little later on today. We'd also like to acknowledge Jeannette Watts, our Ntc Nurse Manager, and one of the project co-leads for this project. She's unable to join us today, but she always stresses the importance that working within these communities is a privilege and an honor, and it truly is. So thank her for that advice. I got involved in this project back in nursing school. I was on a sister project raising student nurses, and eventually that work bridged into this one. So I've been involved now for 2 years. The 3 communities project worked with is cai-u-gat, the furthest up north, Kyuquot, and Huu-ay-aht. All 3 communities are pretty remote. Cai-u-gat and Kyuquot, you need either a plane or boat to access them. And Huu-ay-aht is about an hour and a half or an hour and 45 minutes on a logging road. There's a long-standing relationship between these Ntc communities and this research work. Previous work from projects included training the nurse and a C2 grant. And this team is also strongly supportive of further work. So there's a new proposal that's going in, Learning Our Way, which builds upon the outcomes identified from this project work by the community and what the next steps are. So healthcare service delivery, the Nuu-chah-nulth Tribal Council does have home care and community health nurses covering all three of these regions. Staff retention has been an issue sometimes, but also jurisdiction between Island Health, FNHA, and NTC. There's certain things not covered under some of them, or certain areas not serviced by some of these communities. So it makes access to healthcare a little bit of a challenge. The Ntc nursing team in 2017, all wrapped in blankets. And these are the 4 pillars that are built into the Ntc Nursing Framework. Each life connects, each life seeks fulfillment, each life is a precious journey, and each life completes its cycle. So they really stress the importance of nurses practicing with this in the center. So the nurses have like a baby welcoming, and they encourage the Ntc nurses to support communities that way. And they also really emphasize the importance of elders in community and taking the time to sit with them and learn from them.
White, thank you, Lynn, for that overview and the importance of situating. Oh, is my volume on? Sorry, can you hear me? You can? So my name is Lisa Bourque Bearskin, and I'm originally from Beaver Lake Cree Nation, a Musqueam in Treaty 6, and I'm coming to you today from the traditional and unceded territories of Tecumseh. And it's been an honor and a privilege for me to be able to work with Nuu-chah-nulth communities in supporting the work of nurses trying to improve practices in the community setting. And so when I had the privilege of working with Jeannette, who'd reached out to a number of nurses trying to support her nurses to be able to respond in an effective and more meaningful way so that access to healthcare into these 3 remote communities was practices of excellence. And so what we heard consistently was the challenges that nurses faced in meeting the needs of the people. And how they're governed by, our practice and professional standards, which are important, but it really minimizes and silences and marginalizes the voices of Indigenous people, but also Indigenous healthcare practices. So we came together as a group, and as Lynn was saying, there was a number of other projects leading up to this current project, which is the we were funded by CIHR Research Canada for a Catalyst grant, and it was really looking at the experiences of both nurses and communities when we started talking about traditional wellness practices and what does that look like for them, but also how does that impact their services. So it was really quite dynamic to get that diverse experience from both the nurses and the communities. And you can see our questions are up there. We're quite broad, but we had to come up with some questions for the CIHR research grant. But where we landed, this was a very much co-design with the nurses and the communities in terms of our approach. So using an Indigenous research, community-based research approach, we wanted to root the research in the language. Hence, I will apologize for my lack of ability to pronounce some of the terms here. Learning a new language, let alone my own language, has been a challenge. And so this is what we face as Indigenous scholars, is when we're working in new diverse communities and respecting their own knowledge and language systems. And so we rooted this work in some of the work that NTC had already been doing and really framed out our 4 key phases. And it's really an iterative process. Even though we had some ideas going in, we had to really decolonize our own way of thinking about nursing and how we work with communities. And so what did that look like? So we really started, again, just, bringing the community together, creating our advisory team. We developed a partnership with NTC, which we outlined data ownership, and even in terms of publication and knowledge mobilization and dissemination. So rather than focusing on, the easy activities, somebody mentioned the low-lying fruits would be something like publications, which would benefit more of us research teams. So we struggled with that because we don't really see a lot of the publications really benefiting the community. And so there's a lot of currency in that. And so really having those open conversations about what that knowledge translation piece was going to look like. And then we went into the second phase, which was we worked with the nurses, and we had the nurses. The whole intent of this was to have the Indigenous nurses work with the community to come from a community grassroots approach. But because of the high turnover and exchange of nurses in the communities, that was became a bit of a roadblock sometimes for us. But nonetheless, nurses are very well trained in being able to facilitate conversations. So we did have a number of different nurses, both non-Indigenous and Indigenous. The intention originally was Indigenous, but again, the lack of access to Indigenous nurses working in the community was also a barrier. So it was really encouraging the nurse leads to facilitate the conversations with communities and include themselves in their own analysis. So both the community and the nurses were involved in our data analysis process. We had a three or four step analysis process where we initially went through the data independently, brought it back to our research team. We had a knowledge expert from within the community, Marlene Atleo, who really helped us dig deeper rather than just coming up with concepts. We use this idea of tropes, and it was really a way to conceptualize our findings. But what we found with that was that we really lost the community's voice with our interpretation. So we went back after articulating our trope ideas, and that's kind of where we're at now. The community's just gotten the data back. They've decided what is important key messages for them that they wanted to express coming forward, and we landed with developing this draft conceptual framework. And you'll see here social group, health, time, and communication was central. So rather than, we moved away from the concept idea, the thematic theming. There is some of that, but all of the themes and the stories were placed within these notions of social group, health, time, and communication, because there's such a diverse way of perceiving what time means to some of the community members and also to the nursing professionals, right? That even communicating in terms of how we're communicating with our clients. So there was a lot of mutual exchange happening on, but what was really prominent in here for me as a healthcare provider was listening to the stories on, and this is not new information, with the community suffering and the healthcare system being part of the problem of contributing to some of the issues. And then, just like we've heard with In Plain Sight and all the other reports prior to this, is the impact of racism and discrimination really impacts that lack of continuing of care. It really, even though we talk about situating knowledge within the traditional, it really, healthcare practices aren't situated in that community perspective. So this whole idea that the healthcare is really sick, and then, the importance of taking the time with people, and, how we're working, nurses and health and individuals working and living from this, this constant survival mode that we're in. And so recognizing that, knowledge is housed in that water that you see there on the beaches and the shifting sands of those beaches. Every time a researcher or a new healthcare provider comes in, you lose so much, and then when the tide goes out, you know, you lose a lot of that knowledge and understanding, and then it comes in, you've got a new practitioner coming in who needs to be trained again, right? And so really, you know, there's an essential knowledge base, and there's essential importance of those relationship, that relational practices is fundamental. And so I'm going to turn it over to Ruth now, who will is one of our key leaders in designing this study and ensuring that this conversation was happening in her community. So over to you, Ruth.
Ruth.
Ruth, sorry.
Good afternoon, everyone. My name is Ruth Charlson. I come from this little community. That's the picture of this little community I live in. There's a community, we're very isolated from the rest of the world, and there's not a lot happening here. So this little community of Hot Springs Cove has difficulty accessing good health care for the people. A lot of the health system is sick because we talk about traumas from historic traumas that these people, we all suffer up here, which is never integrated into their health care. So, and the community suffers because of this lack of knowledge about the community's historic dramas. And from these historic dramas, other issues such as alcoholism, suicides, and drug addiction comes from the lack of knowledge. We don't often find anyone that can fit into this community. It's always the other way around, where the worker wants the community to work in their belief system and the way they deliver health. So that is the reason that their community suffers. So we end up on a social survival mode, and because we're unable to get the health care, the proper health care that our people deserve. So we end up, if we don't get the health care right here in the community, we end up going out to the cities like Port Alberta and Nanaimo, which becomes very costly because we are so isolated that we're only accessible by boat or plane. And that becomes very costly. For a 15-minute visit to a doctor in town, I have to spend 3 days there. One travel the day of my appointment and the travel back into the community, which costs me more for room, meals, and whatever else that comes into my trip out to the doctor. So we're just in survival mode. And most of especially the elders here in this community, decide they don't want to go out because it's such a tremendous hardship on them because of the lack of the good quality care. We have so many issues here, and to navigate through the health system becomes too cumbersome for most of us that live out here. So when I was having interviews with community members, that was the biggest issue, was that it's too cumbersome to navigate through the structures and services of the health system that we receive out here. So a lot, because the lack of this, we turn to family and traditional ways, which seem to help this community more than Western ways. This community really believes in family and community values. So we are a very traditional community. And taking the time for the service providers. Their time is only limited. They fly in or take the boat into their community. They have a certain time they need to be out because of the weather or the time of the year. In the summertime, they spend more time here because it's daylight. But in the wintertime, they fly in 1 hour. And how many people can a service provider see in 1 hour, eh? So let's get real. And what needs to happen, Heshput says, what needs to happen is to improve our access to better health care, encounter and eliminate discrimination in healthcare practices, build strong and sustainable community partnerships of future work, uphold Heshput First Nations' right to help and develop their own healthcare system. And so we've begun this developing our own healthcare system by, we engaged this doctor from Osoyo. She comes in every 6 weeks. So we had that ability to do that. So where we seem to be heading in the right direction, but the community is directing the process, not the other way around. That's it, Lisa.
Thank you, Ruth. And over to Kristen or Daniel. Is Kristen or Daniel with us?
Hello. Can you hear me? It's Kristen.
I sure can.
Okay. With Huu-ay-aht, when everybody was doing their sharing circles and talking about their experiences with their healthcare system, it was a lot of talk about the discrimination and how they are treated when they do leave our community to go out and get the medical attention that they need. A lot of them felt like they weren't heard for the most part. Always rushed when they're trying to share share their health problems. Just the lack of treatment there when they take that time out of their day to get there, like traveling on the logging road. It's kind of painful for our elders as is, just because it's a rough road. So they're already tired by the time they get there, and then to be treated poorly, it doesn't make them feel any better. And then not knowing who to even reach out to and talk to when they're feeling rushed and not heard, they tend to just try and tough it out until it's like at the very, I don't know how to say it. They wait till the very last minute where they actually like have to go out to get the medical care rather than going out when their problems first start, or they start seeing the signs of their health failing. So it's just really sad to hear that it still happens. How many years now? But yeah, that was mostly what they were. Their concerns were for our community, is just not being heard.
Yes, and Kristen, one of the things I think was really clear when you guys were talking about is the focus on elders, right? Can you just talk about that?
Yeah, I'm trying to keep them home. I mean, we're working with them as much as we can. The Ntc nursing staff that comes in, a lot of assessments. It's a big priority. We don't want our nurses to feel like they have to take care of themselves. So over this last few years during this pandemic, you've seen a great shift in just how well a community can pull together and help each other out, and the old family values, you know, your family is your medicine. So being able to just reach out to your community it's a big thing for us now. So like, people were pretty closed off there for a while, so building better relationships during this time has been great for our community.
Okay. Thank you so much. I'm going to move on. I think I can't even see my clock on the phone, so I'm not even sure where we're at with time. But we have one more.
Okay.
Samantha.
4 minutes remaining. Sorry, just wanted to let you know.
Okay. So these are our last slides. Samantha, are you? Are you there with us, Samantha? Sorry. I can't.
Hi, sorry, I forgot to the mute thing. I'll try and go as quickly as I can. I do speak really fast. So my name is Ntc, also known as Samantha Christensen. I was involved through this project because we did not have a nurse at the time to fill that role. However, by the time we did get to our first circle, we did have a nurse, and has since gone through at least another nurse in that time. We are a modern day treaty nation who's looking to have self-determination in our whole nations of cai-u-gat and Charleson. And, you know, through what Ruth has shared, through colonization and all the things that have happened through that, we've lost a lot of our own knowledge on our plants and traditional medicines and health. We agree the health system is sick, and those policies that were created back in the day are still alive and well. It incorporates racism and says it's okay to do that way. We've had a lot of community suffering, again, through things that have happened, and the assumptions that come with that. A lot of reports of people not being believed that they're not drunk or had an alcoholic when they've had a stroke, or any other reason for getting ER and attention. We've had elders with ear imbalance also being not believed by healthcare professionals that they weren't drinking. So that's still a big thing of having these negative things on our people. We also are an isolated nation, boat or plane, also the same thing, and especially in the winter, 3 days because of the shortness of the day to do an appointment. Yeah, so yeah, we can't stress our remoteness enough. Like we say for travel, all the other things that happen, not being able to make the appointment because the road's been washed out or the weather is too windy, the boats can't go across. And like you said, has been mentioned, we have a high turnover in nurses in our community. There's a lot going on there with policy and the way this nursing is structured in our area to cover. There's 4 nations that are covered in the northern region of the Nuu-chah-nulth, and it's not like just getting in your car and driving to all of them. You kid with 2, they're fairly close, but the other 2 are fairly far apart. Thankfully, we do have some things happening with emergency response in our nation. We do have emergency responders, and we've also have recently teamed up with Coastal Nations Coast Guard Auxiliary, and so we'll have that training in our area as well. And yeah, so it does take a lot of time and resources to get out. And what needs to happen, we need to uphold our desire to develop our own healthcare system, increased support and focus on elders and youth in our community for services, resources, funding, and access. We need advocacy for policy changes at a multi-organizational level to better fit our communities. We need our unique needs of accessibility, travel, services, and emergency response, and then bringing services back into community and increased delivery of services for elders and youth specifically. So thank you. That's what needs to happen for cai-u-gat.
That's excellent. Can you hear me? Did I mute myself now? Can you hear me? So yeah, so our last slide is where do we go from here? We're doing a bit now. We're going to focus on policy and looking at our policies, trying to revise them so that they're beneficial both to NTC health departments, and so we'll have to reach out between the Interior, some of the other health regional and First Nations health authorities, and having some policy discussions on there. These were the biggest ones that really came out, is the patient travel, continuity of care, orientation to the communities, and so really looking at this intersection of policy and how it impacts intersectionally across all of, you know, justice, education piece. So we're coming up into that phase now. So with that, I just want to, you know, probably out of time for questions, but, you know, thank you very much for entertaining the community. You know, the voice, any kind of research coming out of the communities is really need to be led and designed, and so that's been part of, you know, the time thing to do this research in a good way, is that it has taken its time, but that's okay, because that's where we need to be. So with that, I just really want to thank the community and all of our team members for really showcasing the work moving forward.
Thank you, and thanks to your group so much. The names that I recorded that presented today were Samantha, Kristen, Lynn, Ruth, and Lisa, and I'd like to thank each of you for speaking to this work today and for sharing with us. Very appreciated. And for also teaching me. I learned new pronunciations today. I do appreciate that. So thank you. To folks that still have questions or any questions that are lingering regarding this presentation, feel free to connect with folks through their bios. They're all available on the Feedloop platform. If you're not able to connect with them that way, you can always email my team at research@interiorhealth.ca, and I'd be happy to facilitate the connection over. So thank you guys so much.